So welcome everyone to the UTRGV School of Medicine Neuroscience Research Seminar Series. It's a pleasure actually to introduce the introducer, Dr. Sokolowski, who will be introducing Dr. Libman. So Dr. Sokolowski, I'd like to turn it over to you to do the introduction.
All
and
right.
Please everyone mute your microphones while the speakers are speaking. Thank you.
Okay, thank you so much. I had the opportunity to talk to your group, I believe it was last fall, about this broad topic. It's called acceptance and commitment training. And what I would like to do is, I live in Harlingen and I work throughout the Rio Grande Valley. And when I was talking to Dr. Maestra, she said that she would really like to get information about using this model ACT in a medical setting. And so I immediately thought of Dr. Libman and contacted him, and I would like to introduce him. I'm just going to read his bio. That's going to be the best way. So Dr. Libman is a child and adolescent family psychiatrist with further subspecialization in sports psychiatry and in acceptance and commitment training ACT. After graduating from Ohio University and the School of Medicine at Case Western Reserve University, he completed training in pediatrics, general psychiatry, and child and adolescent psychiatry at the University of Pittsburgh. In addition to serving as the medical director for the PLEA school-based partial hospital program, he has experience providing executive coaching and organizational consultation in school districts, law firms, hospitals, business corporations, universities, and sports teams. He is also a peer-reviewed ACT trainer of the Association for Contextual Behavioral Science, and that is the International Association for ACT. He has presented at such conferences as annual meetings of American Academy of Child and Adolescent Psychiatry, the International Precision Teaching Conference, and annual conferences of both the Association of Applied Behavior Analysis International and Association for Contextual Behavioral Science, most recently on topics involving application of ACT in organizational settings. So Dr. Libman, I will give the floor to you, or the bandwidth.
Well, thank you, Stephanie. I appreciate the introduction. We'll dispense with much about me. Let me just say that the Association for Contextual Behavior Science at this point is a 10,000 membership globally. It's a mix of research scientists and clinicians, and the dialogue seems to work very well between the two. And so my agenda today really is to spend some time with you introducing ACT in a variety of different contexts, allowing time for a discussion along the way if there are questions. And Stephanie, if you or someone can monitor the chat, and if anything comes up, you know, that you really want to stop me so that you have a question that you want to address, by all means, let's use that, although I won't track that myself. And then we'll discuss towards the end. Okay, awesome. Well, so if we were meeting in person, I might distribute these finger traps, and we would all have an opportunity to, you know, stick our fingers in there and get them stuck and try to get out by pulling against and struggling against. And we wouldn't get very far with that because, you know, the more and more you the more and more we struggle against it, the tighter it gets. And so the idea with these finger traps is to just kind of relax into it and counterintuitively push our fingers together. And then we're able to relax a little bit and we can get our fingers out. And so this serves as a useful metaphor for ACT in that we're trying to struggle less and make room, accept what's going on, and in that context then feel some release and be able to get on with our lives. So a little bit of a breath for you and for me. So what I'd like to do is start out with a research study and not belabor it, because what I'd like to do is just show you this And then if you'll bear with me for an hour or so, we'll recircle back to this study and talk about this in a little more detail. But as you can see, this study is aimed to explore the impact of care stressors and demographic factors in people who are taking care of those afflicted with dementia. And it turns out that psychological inflexibility turns out to be a huge factor in how things go for carers. So this study involved 89 folks, mean age of 69. And psychological inflexibility really proved to be a common factor in people who are having difficulty. And so what was concluded was that ACT might be beneficial for this population. And in particular, they made mention of the idea of online ACT as having some potential for future research. And I have involved with a few colleagues in a kind of study, online ACT, for fathers of adolescents with Prader-Willi syndrome. And so when we circle back to this article, I'd like to talk with you a little bit about that as well. So here's our agenda today. We're going to talk a little bit about ACT and then look at it at different levels. ACT with individuals, ACT with families, groups, and organizations, and then we can explore some possible future directions. And I'm hoping this fits the bill for what you all were looking for in today's session. So if we look at ACT, just to put some words, and there are measures that go along with all of the constructs that we're going to talk about, but it's an empirically supported behavioral approach, all of which are important, right? There's a good deal of empirical literature. It is behavioral, and we're really focused on developing skills for living with greater psychological flexibility. So acceptance entails becoming more aware of our inner and outer world, and this means making room for what shows up. It's not acceptance in the sense of passive resignation, but it's really actively learning to make room for what shows up while committing to pursuing a valued course of action. And as we deal with adversities we all encounter along the way. And then psychological flexibility increases as we become more skilled in living with greater awareness, openness, and engagement. So when we look at this more specifically, psychological flexibility is a behavioral process of determining, implementing, and making warranted changes to sustain a valued course of action, especially under challenging circumstances. So this is about showing up, but it's also about staying the course. So this is a composite process with component skills and awareness. That is the ability to be aware of what is happening externally and internally. So ACT has strong connections with the mindfulness tradition as it's been evolving here in the West over the last 30 years or so in particular, really kicked off by actually my first encounter with mindfulness that came in the form of a research that John Kabat-Zinn published regarding his work with in the dermatology clinic at UMass Medical Center. And again, openness is the ability to open up, right? To relax our fingers into that finger trap and then to be able to deal more effectively and engage in staying the course and doing what matters, even when we're being challenged. And again, there are measures that go along with psychological flexibility that are available if there's to be a further research conversation. But the idea with ACT is not so much that we're opposed to reducing distress. I mean, who wouldn't, want to have less distress? But the focus of ACT, the aim of ACT really is to expand and enhance our involvement in our lives. And sometimes that means the distress just goes along with the ride. And so we learn how to make room for that as we get on with our lives. So this is a really cool study done by Paul Atkins and Robert Stiles, who are in Australia. These guys just live, they live in a different part of the planet, literally, with what they do. But they developed a structured interview that is designed to measure self-discrimination, defined in terms of participants' ability to verbally convey their values, right? So this is in contrast with what I should do or have to do, and a sense of perspective about themselves in contrast with getting caught up in our personal stories. So this is a coded interview. And then what they were able to demonstrate is that valuing and perspective taking predicted better psychological health at 6 and 12 months. Their coded interview is available. The measures they use for psychological health are available. But I just thought this was a really cool study. This is their original one. They've since done a replication, and that's available as well. So to give you a sense of what we're talking about here, so, here in the Berg, we talk about, our Steelers, maybe not this fall, it remains to be seen just what's going to happen. But here's Heinz Field, kind of up close and personal, right? And then if we step back from it a little bit, you start to get a sense of Heinz Field, and you start to look around with a little more sense of a perspective, and you see that yellow thing across the bottom that's a little hard to tell what it is. But when we step back a little more, we see, oh, wait, that's the top of a bridge. And now we start to get a little more of a sense of the broader context. And if you notice off to the left, there's the Science Center, and back off to the right is Allegheny General Hospital. And you even get a sense of why the stadium that was there before Heinz Field was called Three Rivers Stadium, because we have the Allegheny and the Monongahela coming together to form the Ohio River at the point. And if we step back a little bit more, then we even get a broader sense of the mountains surrounding Pittsburgh. And so we have a different sense of perspective. Now, the interesting thing is, if you ask about, well, what changed, right? A lot of people will say, oh, well, you must have been moving back. And it turns out, I stood in the same place for all of these pictures on top of Mount Washington. And I had a telephoto lens, so I was able to zoom in and then zoom back out. And so the challenge we face, right, is to be able to develop a sense of perspective and get a little less caught up in the nitty-gritty. Although if you're actually playing the game of football, it helps to be in the stadium in the middle of the nitty-gritty. But in the game of life, it turns out being able to step back and maintain a sense of perspective can be incredibly helpful. And that's part of what Atkins and Stiles were trying to get at, perspective taking as a crucial skill in predicting psychological well-being. Well, okay, so our lives are filled with nots. This is a pretty good knot, right? The first principle of medicine, primum non nocere, right? First, do no harm. I've interpreted this variously over the years. If you're going to screw up, be creative. It is a pretty helpful guideline to keep in mind. But it says first, do no harm. And that leaves open the question of, well, what do you do next? So that's of concern to us. Illegitimi non carborundum. This was the banner under my medical school newsletter at Case Western Reserve. Loosely translated, right? Don't let the bastards grind you down. Another pretty good knot. And our lives really are filled with this, right? This is what we say to little kids all the time. Don't be sad. Don't cry. Don't be afraid. Don't be upset, right? Our lives are filled with a lot of don'ts. But what do we do? Well, Francis Peabody told us back in 1927, right? The secret of care of the patient is in caring for the patient. And so ACT is really all about caring with a sense of perspective, valuing and caring. And so too, this is what Stiles and Atkins were speaking to when they talked about perspective taking and valuing as in terms of how it informs, how it imbues our conversation. So if we start to put this together with the ACT matrix. And there is a more expanded version of ACT called the Hexaflex that gets at some of these processes in a more detailed way. I'm going to stay with the matrix today because I think this is particularly useful and relevant clinically. And so when we start to look at the matrix, right, you'll notice right away, I draw this with a 3D box in the middle, and that's intended to convey this sense of perspective, kind of from Mount Washington, the stepping back. And we make two key discriminations. We discriminate inner behavior from outer behavior. Outer behavior is if we put a video camera on you and we could see what you're actually doing. And inner behavior speaks to our inner world, our thoughts, our feelings, our emotions. We're behaving, but we're behaving on the inside. And then we also discriminate towards and away. Towards is moving towards doing things that we like, that matter to us. Away are the moves that we make to get away from our distress. And so we wind up with 4 quadrants, and each quadrant has a question. There's a word that goes along with it. And so here's our caring, here's valuing. And the question that we might ask of a patient, of a family, of a group, of us as we participate in this seminar is who or what is important to you. And if you just take a moment and just see what comes to mind, how would you start to respond to the question, who or what is important to you? And if I'm talking with a parent of a child with autism, we would start to hear comments like the ones that you see. You know, we're not looking for esoterica, right? It's the stuff of our lives, you know, who or what is important to us. And yet, as soon as we start to care about anyone or anything, the plot thickens a little bit because along with caring goes distressing. And the question here is what shows up that gets in the way of caring? And shows up is the operative notion here. You know, none of us look for distress, but it just sort of shows up. And so what's showing up that's causing distress in your lives these days? Well, a lot, right? A lot shows up. A lot of stuff, feelings and thoughts and judgments and complaints, right? The whole panoply of human emotional reactivity is what shows up. And we humans know what to do when that shows up, right? We avoid, we move away. What do you do to move away from your distress? The human distress response, so-called fight, flight, right? So what do we do to move away? We're not all that creative, really, right? I mean, what do? We procrastinate, we gossip, we punish, we blame others, we yell, we drink, and so, right, I mean, I think it's really important. I showed you pictures of Pittsburgh, and that's really different from your context. And yet I think what stands out for me is, as I've worked with people from different cultures and traveled around our planet, is that because ACT is based in human behavior and principles of applied behavior analysis, behavioral science, I think some of these issues really transcend culture, allowing for the unique manners of expression within some cultures. Well, the challenge we face is one of engagement. So what can you do to move towards who or what matters to you, even with your distress? And so what do? I mean, how do you show caring to your family, your children, your coworkers? Well, you spend time together. You attend to health issues, right? You provide support. You're present and accounted for. And the even with distress part speaks to this vector, right? This is kind of a vector of psychological flexibility. This is how do we move towards being engaged in doing things that matter, even when the going is tough, right? That's what psychological flexibility, that's what awareness and openness and engagement are all about. So that's the ACT matrix. Now, obviously, if we're doing this in a clinical setting, we move slow through this a little more slowly and a little more deliberately than I just did, but I'm just trying to give you a feel for the game we're playing, so I wanted to get this up on the screen pretty quickly. Well, so our three skill sets, awareing speaks to this middle pillar, right? And then here's where opening, accepting shows up for us. And here's the engaging skill set of those three components of psychological flexibility. Well, so if we talk about awareing it, and when we do act, we're looking to also do some training. So this isn't just a conceptual model, but we're really looking to build skills. And we can do this in various ways. I mean, for right now, I could ask you, and if you're willing, please go ahead and just, close your eyes and just take a really slow breath, breathe in and breathe out. And then just listen to the sounds in the world around you. Just let sounds come to you. My voice and the pauses in between, and maybe the sound of your own breathing and other sounds. And it's really hard for us humans to hear a sound and not try to label it. Of course, back in the day out on the savannah, it was really helpful to be able to quickly identify sounds. But as soon as you notice yourself labeling a sound, just let go of that and await the arrival of the next sound. And the sound after that, and the sound after that. Now, we can do breathing exercises, although some of what I'm presenting to you today is from work I did at the University of Pittsburgh Medical Center with the palliative care service there. And there, and I'm sure you're seeing it these days too, when you're dealing with people who have any degree of compromise in their breathing kind of exercises are problematic. But the auditory channel is an interesting one, and we can do this by listening to a favorite piece of music and then really listening, really listening to the vocalists, really listening for the different guitars, really listening to the drums, really listening to music that we're listening to. So that gives you a feel for the awareing component. Now, we can also move from finger traps to thought traps. Now, how does that work? Well, something happens, right? We react and start to tell ourselves a story, and boom, we get stuck in our lower left quadrant of the matrix story, right? I could ask for the hands of those of you who have not had this experience, but I can't see your hands and I don't need to ask anyhow, right? So what do? Well, I do need your hands actually. So on your left hand, I would like you to imagine the words written there that say, I'm the kind of person who has trouble with. And on your right hand, fill in the blank with whatever kind of trouble you have. So if you look at your hands at arm's length, you see, I'm the kind of person who has trouble with whatever ails you. And then I'd like you to take your hands and cover your eyes with your hands. Cover them pretty well and look around the room and notice what you see. Not very much. Now keep your hands up there. And now I'd like you to slowly start to spread your fingers and slowly start to lower your hands towards your lap and look around and see what you see. With your hands down, you see everything. Now notice, on your hands, right, you're still the kind of person who has trouble with whatever ails you. But what we just did was we changed our relationship with that thought, stepped back from it a little bit, developed a sense of perspective about our thoughts. And that's what ACT tries to do here. ACT is interested in changing our relationship with our thoughts and our feelings and our reactions, not doing away with them, not disputing them as you might in a more cognitive behavioral model, but really just to make room for those thoughts. And then we can take them with us on that vector from the lower left quadrant to the upper right quadrant, kind of having our thoughts rather than being our thoughts. And so able to kind of open and get on with our lives. So that's the opening. That's the left side of the matrix. That's that skill set. And then there's engaging. And we can go about engaging in valued behavior in a variety of different ways. Here's an exercise that I will use in training workshops. And again, I'm going to move through this more quickly than I would ordinarily, but I'd like to give you a feel for the exercise. So here's a question. If you could be 3 to 5% more the professional you aspire to be a year from now, how would you be behaving differently? 3 to 5%, I mean, a wee little bit. If a year from now, right, you could be a little bit more together a professional, how would you be behaving? And just take a moment and just see what comes to mind, right? There's no right or wrong answers here. This is just a little thought experiment. And then you can ask this question of yourself. Why does this matter to you? What valuing, what caring is there underneath the aspiration such that this matters to you? And then we can do a little bit more of an exploration related to valuing. Not today, but feel free to take the exercise home if it happens to strike your fancy. But I think you're already getting a sense of how we move around this. So we don't start in just any one quadrant. We can really start anywhere. But in this exercise, the next question for us is, so what's going to show up and get in the way of your professional aspirations? Knowing what you know about yourself. What's going to go on the inside? Doubts, inner dialogues, narratives that you got going in your head about yourself, right? And this can be done in a really deep exploratory kind of way. The T in ACT is used in two different ways. It's used in medical settings for the most part to mean training. So we're really focused on skill training. The T also can stand for therapy, acceptance and commitment therapy. And then, in other settings, in a psychotherapeutic setting, then it might lend itself to a more in-depth kind of exploration. Well, the avoiding question is, how might you go about undermining your efforts to achieve this change? What do you do to kind of, knowing what you know about yourself, what do you do to kind of engage in acts of self-sabotage? And then that can be pondered a bit. Now, this is a behavioral model, right? So when I do this in a workshop, I'll ask people to say, okay, let's circle back to that upper right. So what would you need to be doing in a month that would lead you to say, hey, I'm on track for where I want to be a year from now? And I'll have people put prompts in their Outlook a month from now so that they know to check in with themselves. And of course, we can nail this down a little bit more. And I can say, okay, well, if you were making progress, what might a colleague see you be doing next Tuesday that would lead you to think, hey, that's a small step? And we can put a prompt in Outlook for that, or Google Calendar. But we could also ask it this way. What could you do between now and bedtime today? What small step could you take over the next few hours that would be just a little bit of progress towards where you want to be in a week and in a month and in a year? And the key thing here is this. In that lower right quadrant, when we say who and what matters to you, check it out. We all know what we should say. We all know what's socially acceptable. We all know what we should say to look good. We all know what we need to do to be right. But that's not the same as tapping into what really matters to us enough that it facilitates our persevering when life challenges arise. And so what we're really looking for is to get that kind of process in motion, because that's what it really takes to sustain us in the face of adversity. And so by way of rounding things out then, I hope you're starting to see that these ideas of awareness and openness and engagement aren't just abstract constructs, but we really use that to start to inform specific kind of skill training that we can do to start to lead our lives in a little different a way, in a psychologically flexible way. Okay, so I also said this is an empirically supported model, and here's the website for the Association for Contextual Behavior Science. And it turns out that at this point, there are somewhere around 300 RCTs of ACT across a variety of different kinds of conditions, psychological conditions, but also medical conditions, diabetes, cancer, GI disturbances. So there's quite an evidentiary base for ACT. And I just want to show you a couple of 3 studies, not because I want to look at these studies in detail, but I just want you to see the kind of studies that people are doing, and take that with us into the rest of our conversation. So this is a study that was done in London, a 2-arm looking at a feasibility study, right? I mean, advanced cancer is a pretty tough area in which to do research. But in this particular study, attrition was an issue, but ACT generally was viewed more favorably at 6 months. So this helped to establish feasibility. In this particular study, a randomized pilot to reduce a post-surgical pain in breast cancer surgery. This was, again, a randomized pilot and feasibility study. And you can see what they were looking at. One of the things that's striking about some of this research is that in this case, this ACT intervention was a 2-hour individualized session. So roughly about the amount of time we're spending together for this seminar. And they found that this was able to make a difference. So a little bit seemed to go a long way in a pretty tough area of research. And in this,
Libman, we do
yes.
have a question. Shall I wait until you finished all these articles?
No, go ahead.
Okay. This is from Kelsey. It looks like Baker. Has the principles of your matrix ever been employed in tandem with rehabilitation-related trials? For example, rehabilitation for stroke to try to improve achievable outcomes.
There is another body of research that I'm not going to speak to today. ACT is based in relational frame theory, which is a behavior analytic theory of language and cognition. It's really a study of how does symbolic communication develop? How can I be using these words to speak to you with meaning? How can you look at the words on my screen and understand what they mean? And so within the relational frame theory research, there's a body of work that's actually starting to apply this in the area of stroke, in the area of Alzheimer's disease. There's a former president of the ACBS, Nanny Pretzi, is doing some work using relational frame theory as a basis for intervention with patients with Alzheimer's disease. And it's preliminary, right? This is all pretty cutting edge, but but ACT, and especially in the form of relational frame theory, is starting to be applied. And so in this particular study, this again was an RCT, and the form of ACT was a one-day workshop where vets were run through a whole sequence of exercises along the lines of the ones I just gave you a hint at when we were talking about the matrix. But the really cool thing about this study is that the ACT matrix was used as the basis for the workshop. So the matrix was introduced, the vets had a chance to work their way through that, and then skill training was done along those three pillars that I described to you as part of this study. And as you can see, again, a little bit of ACT seems to be making a difference, which I think is pretty cool. That seems to be showing up across studies. So hopefully that starts to give you a little bit of a feel for the research basis and why I'm saying this is empirically supported. It certainly makes it a lot easier to come speak with a group like yours, knowing that I'm speaking primarily as a clinician, but with growing amounts of science behind the statements that I'm making as well. So if we start to shift focus a little bit and start to look at matrixing with groups and organizations, again, we have a pretty familiar model at this point, but think about the zoom lens from Mount Washington. And so now what we're going to do is ask the same question, but we're going to zoom back out a little bit and ask it at the level of a group. And so, again, if we were doing this in more of a workshop or an organizational consultation, we would spend time, even in this format of this Zoom seminar, we could have a little discussion about what is your shared purpose and really look to find some common ground in terms of what inspires your department and what really helps unite you, but also keeping in mind that we're going to zoom in and zoom out. So we're also going to be looking at the alignment of individual responses with group responses. But of course, this is human behavior that we're talking about. So as soon as we start to engage a group of people in talking about their shared purpose, right, there's stuff that's going to start to show up that gets in the way. Emotional reactions to each other, complaints about funding sources, right? I mean, issues are going to arise. And in this model, right, we're just looking to be more descriptive than judgmental. But sometimes what shows up is some pretty significant tension, right? I mean, sometimes we humans really don't care for each other, and there's some behavioral manifestations that show up as a group, right, that kind of gets in the way, and we start to get a sense of the organizational culture and how things are managed, or how things are not managed, for that matter.
So Dr. Libman, we have kind of a long answer about the ACT framework.
Go ahead, let's stay current with this.
Okay, the answer is that ACT framework will generally help in increased commitment to behavior change that aligns with people's values. Once you increase people's willingness to create room for distressing emotions, help them recognize mechanisms of avoidance, unwilling to accept, and increased avoidance strangely increases suffering, increased symptoms such as depression, sedentary behavior, unwillingness to experience some distress, close parentheses, and connect to their values, behavior change that moves one toward their values with acceptable skills training. It is likely to improve committed behavior such as rehab, compliance, etc.
Yeah, I had to work pretty hard to keep track of all of that, but yes, yeah, and that's part of why the valuing matters so much, and building skills for noticing matters, right? Because otherwise, why in the world would we want to wade into our distress? You know, I mean, it's natural to kind of want to get away, but the only reason I'm going to stay with the distress if it's in the service of doing something that really matters to me. But that's also why we really need to see building skills, and this just can't be conversational, because if we're really going to look at what's going on that's eliciting distress, you know, we really have to provide a supportive context in which, even in groups, as I just put on screen, you know, we can help people figure out, you know, what they can do to work together, even along with the distress, even with that vector that goes from the lower left quadrant to the upper right quadrant. So in a word, Stephanie, yes, yes. Well, okay, so now let's start to show a little bit about how we move with this. So now we've shifted to a group level, right? We're still using, if you think about the matrix as our camera, now we've zoomed out so that we can start to see the group, or we can zoom in to see the individual. Well, so it turns out that ACT is also being thought about these days as an evolutionary model. There are strong connections between ACT and evolutionary science. So David Sloan Wilson, as some of you may know, is one of the preeminent evolutionary biologists of our era. And he has really done a nice piece of work looking at multi-level selection, looking at not just individuals, but also at groups and the processes involved in group selection. Looking, for example, at how altruism makes little sense at the level of the individual, but it starts to make more sense at the level of groups. And in his latest book, This View of Life, David Sloan Wilson is speaking to multi-level group selection, and he really would like to see evolutionary thinking extended to groups and organizations and societies, and even a planetary view of what do we need to do collaboratively, for example, to address issues of climate change. So it's also a pretty cool thing that this evolutionary biologist has a section on ACT, and he actually has the matrix in this book, and goes through a pretty sophisticated analysis of the role the matrix has to play. And furthermore, this has been extended now in a conversation of an edited volume with David Sloan Wilson and Steve Hayes. Steve Hayes is the main proponent of ACT. There's a group of people who were at the heart of forming and studying the model over the last 30 years, but Steve Hayes was the prime mover, and he and David Sloan Wilson have struck up quite a collaborative relationship in looking at how ACT can be seen from an evolutionary perspective. And the way that plays out is, now I've shown in the lower right quadrant the individual and the group question, because this is now multi-level selection, so we can focus on individuals and we can focus on groups. But if you think about it, the essence of evolution is variation, selection, and retention in a particular context, in a particular niche. Well, when we help people learn to sit with their distress, what starts to open up is the possibility of starting to behave in different ways, not just moving away to the upper left quadrant, but starting to entertain ways of, along with this distress, how could I start to behave differently? And then, as our values become clearer, they start to influence the behavior that's selected. I start to do new and different things along with my distress that matter to me. And then, as I am positively reinforced by engaging in newly selected, valued behaviors, those new behaviors start to be retained in the broader context of my life. And so with the variation, selection, and retention in context, ACT is being thought about more and more as an evolutionary model. But the plot thickens further. So it turns out, and this may seem like quite a digression, I promise you I will tie it back in fairly quickly, that Elinor Ostrom won the 2009 Nobel Prize in Economic Sciences for the work that she did developing these core design principles that allow for the sustained and equitable management of shared resources. Now, this is really pretty remarkable because she's the only one to ever win a Nobel in economics for more qualitative than quantitative research, which is not to say that she wasn't oriented to the quantitative, she was. But at the same time, what she discerned were these core design principles. And she started out looking at water management in California, looking at fisheries and irrigation systems around the world. And now her research has been extended such that it's being used, for example, in metropolitan police departments, looking at how precincts interact with headquarters. It's being used in corporate settings. Robert Stiles, who I mentioned to you earlier, uses her work in his consultation, and he was engaged in a project in which they did 30-year longitudinal planning for the Australian National Railroad. Because I guess if you want to have a train service that spans the Australian continent, you have to think long-term, and you really have to think about how are you going to manage all that needs to be addressed to pull that off. So Elinor Ostrom won the Nobel, and this caught David Sloan Wilson's attention. And so in the intervening years, 2 or 3 years before she died, they'd started to do some work together looking at how these core design principles could be incorporated into groups. Recall David Sloan Wilson is interested in multi-level group selection and in promoting that. And so this really became important to him. Well, it turns out that a researcher from Oregon, Tony Biglin, who was a huge player in the tobacco research and in changing our culture around tobacco over the last 30 years, introduced David Sloan Wilson and Steve Hayes, and they developed this method that's being called prosocial. And what prosocial does is it integrates Ostrom's core design principles with the ACT matrix to promote organizational flexibility. And so if we take this group level matrix and introduce Ostrom's core design principles, her first principle is strong group identity and understanding of shared purpose. And I think you can see how nicely that maps into the lower right quadrant of the matrix. And then the next set of principles offer a more refined way of really organizational diagnosis and looking at what needs to happen to help a group function more effectively. So it turns out there needs to be fair distribution of responsibilities, costs, and benefits, fair and inclusive decision-making. And notice these don't say what to do. These just say, these are principles, these are issues that need to be attended to in order for a group to function well. There has to be some sort of monitoring of agreed upon behavior. And notice how noticing in the middle of the matrix could easily be replaced with the word monitoring at the group level. And then we're in business with our perspective taking skill training. There has to be warrant of course corrections. Right now, this is human behavior we're talking about. So it's not as if we don't misbehave in the upper left quadrant. This says, of course we do, but we have to have some way of monitoring and noticing and getting back on track, including having a way of resolving conflict. And then we have to respect autonomy at each level for the individuals and for the group. And we have to look at how we're collaborating with other groups. And once we start to step back enough, zoom out enough to see that, then we can go back and apply all 8 principles now at the higher level, looking how a given organization is functioning as part of a consortium with larger levels of organization. And so the research in applying ACT organizationally now at the leading edge is looking at how do we do this pro-socially. Okay, time for me to take a breath. That's a lot, but I wanted to give you a feel for these different levels of applying ACT organizationally, especially because I think this starts to have some interesting implications for possibilities that we might start to imagine together. So now we're talking about variation, right? But now we're talking about it at the level of both individuals and groups. We're talking about selection and retention, but we're doing that at different levels of as well, in the context of our lives and of our organizational lives. And this now has received a book-length treatment about prosocial. Paul Atkins, whose name you'll recognize from the Stiles and Atkins research on self-discrimination, has teamed up with David Sloan Wilson and Steve Hayes, and this book has now been out for a year or so, and it's growing. They just did a major study in England with a number of different organizations, and prosocial, as with ACBS, is becoming a global phenomenon. So there are pro-socializers in various countries around our planet. So that's a quick touch on pro-social. And so now let's start to glance towards possible futures together.
Quick question.
Sure. Okay, I'll listen carefully.
Organizationally, is easier to apply ACT with new groups or with well-established groups? So is it easier to apply ACT with new groups or well-established groups?
I think it's a little easier with new groups because we don't have as much history to overcome. We may have a higher level of anxiety, but we don't have history. If we're dealing with an established group, then the narratives in the lower left quadrant and the cultural ways in the upper left quadrant of misbehaving can be pretty well entrenched, and so that can pose a challenge to the organizational consultant. Not an obstacle, but a challenge.
Yeah. All right.
So now let's turn our attention to medicine. Romana Humanfar is a behavior analyst in an ACT person, and she directs the behavior analysis program at the University of Nevada, Reno. And she has done, they now have a decade or so of collaboration between the departments of psychology and the medical school, including the dean. And so one of the things they started to look at in their longitudinal collaboration are issues of implicit bias in medical students that shows up, for example, in their observation that medical students were spending much less time in the examining room with an obese patient than with a thin patient. And they would swear up and down they weren't biased, but these implicit biases kick in pretty quickly. And so they have done a series of studies such that they now actually have woven ACT into the medical school curriculum, and they're also doing a longitudinal cohort research. So when I I've known Ramona for quite a while, and when I told her about this talk, she said, well, let them know if they're interested in some sort of collaboration, that we certainly can have some discussion. So that this may go beyond the scope of anything we should be talking about, but I figured I would mention it just in case it happens to be of interest. The IRAP starts to get at what I was talking about with the RFT, relational frame theory. So it's a way of starting to look at implicit bias in a different kind of way. But you can see that they're also extending this to burnout and to issues of cooperation and collaboration within teams. So if there is room for some follow-up discussion about this, Ramona has said that she's willing to engage in dialogue. And then as we move back to the study that I said that we would circle back to, so this was a meta-analysis that predated that study, in which the same researchers reviewed the literature and noted that there was strong empirical support for cognitive behavior therapy in general, but they also noted this newer approach that was entering into a dementia related to ACT. Although there was one earlier study of ACT and CBT that I think happened in Spain in like maybe 2009 or 2010. And in that study, ACT and CBT were roughly equivalent in being helpful. But here they suggested there was reason to take a harder look at ACT, which then led to the study that we started out looking at an hour or so ago. And now I think you have a little clearer sense of what they mean by psychological inflexibility. And again, the idea here is to be much more descriptive than judgmental. I mean, someone involved in long hours of caring for a patient with Alzheimer's, right? I mean, it's pretty hard to maintain a sense of perspective. It's pretty hard to not get caught up in the inner reactivity and inner dialogue. And so it makes a certain amount of sense that, you know, people who struggle with those kinds of issues are just going to have a more difficult time of things. So here in this study, right, as we looked at before, this is the population they studied, and they found psychological inflexibility to be a pretty common factor in looking at difficulties that people were encountering, and concluded that ACT, especially online ACT, might have potential for future research. Well, okay, so here's our model. And in terms of that last point, online ACT having potential for future research. So much like I am hardly an expert in Alzheimer's disease, I am also not an expert in Prader-Willi syndrome. However, I have an office mate who is an internationally renowned expert, and she and two of her colleagues approached me and said, would you be interested in piloting a project with us of ACT for, and these women all said, for fathers of adolescents with Prader-Willi syndrome. And I said, well, why the fathers? And they said, because the mothers don't participate in this kind of research because they're all so overwhelmed that to talk about even trying to be helpful feels like a burden to them. But we figure if we can connect up with the fathers, then maybe we can make a difference for the families. Well, it turns out we did get funding for this, but then COVID-19 hit. So the project has, as you can imagine, been pretty difficult to get underway, especially because since Prader-Willi syndrome is a pretty rare condition, the recruitment, again, a part that I've not been directly involved in, the recruitment has been national. And so we're just now looking at getting the pilot project underway. So I can't tell you, here's our data, here's what we're finding. What I can say is, and I think you'll see the method to our madness, What I can say is we're going to do these 4 online hour-and-a-half sessions. In the first session, we're going to introduce the matrix like it was introduced a little while ago in this conversation. So we're going to give people a feel for the matrix, and that's going to be session 1 with a little bit of homework, including asking the father to go home and explain the model to his wife. And then we're going to do 3 subsequent sessions, which I think you can guess are going to focus in the second session on awareness and skills for awareing. The third session is going to focus on some skill building and some exercises and some homework for opening. And then after that, we're going to do a session on engaging and draw the little project to a conclusion, much along that exercise that you saw of where would you like to be a year from now, and what does that mean a month from now and a week from now, and what can you go home and do today? And so we're just going to look to see if we can do a little skill building across 4 sessions and pilot the project in this way.
And we've got a question. What are the steps involved in learning how to deliver ACT? Are there training workshops? Do you need a specific type of degree to deliver ACT?
Well, I think thank you. That can certainly be part of the conversation that we're having. I mean, yes, that there are different ways. I mean, there's a literature. There are people who are running online workshops. There are conferences. Well, these days they're more cyber conferences than actual conferences. And we might be able to have a conversation as part of the discussion we're moving to. So that question was not a plant. Let me just let everyone know. But that's just where I wanted to head with our conversation here about possibilities. Clinically, educationally, and research-wise. So yes, there's training that's available more generally, and we might want to have a more specific conversation if there's room for us to have a discussion about what kind of collaboration we might be able to do, what sort of training I might be able to do. So not that it has to be limited in that way, because as I say, there's quite a bit that's available out there. So that can be part of where we go with our conversation. And so to set the stage for that, right, I hope we've done a dance across these 4 acts, and I'm certainly available by email. So let's just open things up and see what kind of questions and issues arise as part of our discussion.
So Stu, thank you so much. This has been really wonderful at so many levels. I'm so happy, and thank you, Stephanie, for actually, leading us to Dr. Libman. And a lot of questions in my mind, but I particularly wanted to thank you because we have a lot of presenters, previous presenters here, but I have to say that I felt that the session was not only informative, but therapeutic itself. So I thought that was good. We have also here residents of psychiatry, but I'm particularly eager to see how Dr. George Deepu sees this opportunity at the level of organization. Dr. George is one of our faculty at the Family Medicine. Also, he is part of the Bioethics Institute. And he wrote an email and he said, well, I'm based my practice on ACT. So
oh, really? Wow.
So maybe I'm putting on the spot, Deepu, but I would like to share with this audience, taking advantage that we have Dr. Libman and Dr. Sokolowski here. to share what, how you see this in our school, how advanced we are in the school, open to this kind of frameworks.
No, I am Dr. Libman. Honored to hear you. I've been an contextual behavioral science geek since 2013 when I started my fellowship. I trained family medicine residents in acceptance and commitment therapy to be applied in primary care. And I started last week a brief training for the psychiatry residents on ACT as well, so that they can be more aware, more flexible. And I am biased in saying this, but I think ACT is a very powerful and theoretically parsimonious framework that easily allows non-pathologizing conversations while relying on people's strengths to help them move towards their valued and vital living in the presence of extremely distressing emotions and complications that, well, for the lack of a better word, human life offers each of us, right? Even in the midst of this pandemic. And I think one of the things that I'm excited to see is the sort of the pro-social movement. Dr. Anthony Biglin was one of our consultants for our project when we started the Integrated Behavioral Health Project here. And his book, Nurture Effect, has been a big influence in the way we think about the power of behavioral science and behavioral medicine in the world, but particularly in prevention. So I think it has huge implications for UTRGV if we are truly willing to engage and have some hard conversations around what do we care about, what kind of systems do we want to put in for monitoring, how are we going to be more accountable when we move away from our valued behaviors, and what kind of things can we put in place in order to be more committed to our values as an organization. But maybe if not at the big UT system level, there's still possibilities for, let's say, the research core or other groups. So I'm, yeah, I'm very biased, Dr. Libman. I'm not a plant that you put in here as well, but ACT has been my life for the past several years.
Well, all so very cool. Tony Biglin is one of my heroes. I mean, he's had a remarkable research career at all levels,
Yeah.
local as well as national, and he's been involved in a number of global organizations too. And well into his 70s, he's still very actively tackling climate.
Yeah.
But to your point, yes, we certainly can entertain how could this become entered in at any of a variety of different levels of the system. Dr. Bruce Errol is a professor of family medicine at the University of Auckland in New Zealand, and he has structured his entire residency program around ACT. Just as a quick example, as part of routine care, he's asking people to identify one small behavior they're going to work on between now and the next visit. And they have to say there's an 80% chance I'm going to actually do this. So if they're working on weight and someone says, I'm going to lose some weight, I'm going to change my diet, I'm going to go to the gym every day, he says, no, you're not. No one's going to do all of that.
Yeah. That's a
could you get to the gym once a week for the next 3 weeks before I see you back? Yes, I can do that. Okay, I'm going to write that down, and we'll see in 3 weeks if you got there one time. I mean, it's a behavioral activation component where he's looking to get people in motion, but he's really woven it into the fabric of the way they practice medicine.
Right. And so a lot of the work that we do here, we do brief behavioral consultations in primary care or other medical settings. And, we have probably 20, 30 minutes with patients, but our fundamental goal is, can we help you change something, right? And I think to your point earlier, your behavioral invariability and experiential avoidance can almost explain all of pathology, maybe psychopathology to a great extent. If you look at across the DSM characteristics across disorders. So if we can increase experimentation and increase willingness to do something they haven't done before, you're most likely starting people on a path of change.
Well, indeed. And then what pro-social starts to open up is what do we need to do to engage the system in making the changes necessary to facilitate the incorporation into clinical care and research. And so it's an interesting model. I mean, we use that in the program I serve as medical director, the school-based partial hospital program for kids with autism. But I've also used pro-social in consultation with multinational corporations. And Ramona out at UNR is having consultation with the dean of the medical school. And so they're really looking at how do we use this at the level of the entire school. But obviously to intervene in a system, you know, we want to get as high up in the system as we can. And then we can look to see what changes can be facilitatory of projects that are ACT-based. So way cool. Thanks for your comments. It's really awesome to hear what you're doing. Other thoughts, other questions?
I have a question. I'm now Martinez. I'm with the School of Nursing. And my area in practice and research has been in diabetes, particularly among Mexican-American individuals, type 2 diabetes. Those individuals certainly, well, we see children at this point, adolescents, all the way certainly to elders. And I really thank you for your presentation. I was excited to take part in this to learn more about it, because I can't say that I really am so aware of this. You know, diabetes, we're so into diabetes self-care, self-management. You know, it's a behavioral type approach, and there's certainly multiple dimensions to it, their cognition and, you know, affect and so forth. I guess I kept thinking as I was trying to process, you know, your presentation here was, you know, working with the patients that, you know, have, you know, it's a multiple complex disorder or disease that they have. It's not simply an altered blood glucose level, and particularly the length of time and the degree of control they've had. We're talking about those who have neurological complications and vascular complications. I've worked a little bit with, you know, Alzheimer's and vascular dementia elements, because those certainly by age alone and by diabetes. And so I guess I'm still trying to capture, you know, how you can take an ACT type of, you know, intervention or program and apply that to individuals who are at high risk, you know, with really altered metabolic control, and have that, you know, really to their, you know, their success in not just managing their diabetes, but their overall quality of life, as well as that of the family. Many do reside with family in our community here, maybe sometimes 3 generations of family in a home. So I'm just wondering if you had experience with patients with diabetes, particularly by cultural groups, and those with multiple, you know, and complex disease states.
Yeah, thanks for a really important issue, important summary. It turns out that the lower right quadrant looms large. And even as I say lower right quadrant, I mean, you know, we had an hour conversation, and I think I can start to say lower right quadrant and everyone nods their head. You sort of see, yeah, valuing, caring, right? So the other thing we're finding is that people get this model pretty quickly, but the lower right quadrant looms large, right? Because we can bust people's chops about what they should do.
Exactly.
Good luck with that. But
exactly.
But if it's who and what matters to you, what do you want to get done in your time on planet Earth? I really want to dance at my granddaughter's wedding. Oh, well, let's think about what we need to do between now and then to get you on that dance floor.
This may evolve over a step process. For example, if I see a patient and they're, you know, hemoglobin A1C levels at a 9 point something, you know, their blood pressure is still a little bit out, and again, another medication they're taking, you'd have to reach certain stages in order to better actively engage in this process here.
Yeah, that's it. That, you know, so, okay, so if we're going to get you to that wedding, what's one small thing we need to work on as a next step?
Mhm.
And with the matrix in play, we can also ask, and what's going to get in the way of that? What are we going to watch for? How are we going to know when we're on the left side and not the right side?
Mhm.
And right, so we want to have all of that in play because the left side's going to show up. It's going to show up.
Makes good sense.
Um,
I need to
I just
call
had a
you. I'll be one to
conversation.
give you a call for sure.
Yeah, well, I just had a conversation with the university about, they really want to do more with diversity and inclusion
Right.
in the lower
Mhm.
right quadrant. They want to celebrate diversity and inclusion. And I said, that's way awesome, but you're going to exacerbate lower left quadrant tribalism.
Mm.
What? Well, watch, see what shows up. And so we have, and that's not reason not to celebrate diversity and inclusion. Oh my God. But get ready because we're going to fan the flames of tribalism with that conversation. I mean, look at what's going on, hello in the good old USA. So yeah, so we need at all levels, we need to allow room for both. But the key thing, I think, in chronic illness and working within the capabilities, right? Because if people are neurologically compromised, this emerged in my work with the palliative care service, as I mentioned, right?
Mhm.
Breathing meditation, right? I mean, when everyone's taught, let's do this little 1-minute breathing meditation. Not if you're compromised in the respiratory system, it's not a great idea. It's also not a great idea in post-traumatic stress disorder with Marine sharpshooters, I learned painfully, because, they're taught to take a breath with the target in sight. And if when they finish that breath, the target is still there, then they take the shot. Well, breathing meditation re-traumatizes and brings it all back. Auditory channel is a whole different way to go. And so we can do the skill building, but to your point, I think that lower right quadrant really looms large in being able to engage people in a meaningful fashion. Because if that's not there, all we're doing is, busting their chops on the left side, and that doesn't work so well.
Thanks.
Indeed. Awesome question. Thank you. It's a lot, and this doesn't have to be the final word, Gladys, if and as there's room for us to follow up and think about, implications at whatever level. I tried to weave in some of the research, to provide you with a sense of the kinds of questions people are trying to investigate. I'd like to be able to give you some data on what we're doing with this little online project we have. We're just not at that point, but coming out of that, the research project that I cited, it may be a way of trying to see if we can get a little skill training in play.
No, I would love to. So who can be delivery agents for ACT? Going back to the Kelsey question. Do you need to be a psychiatrist, a psychologist? Do you need to be, what are the restrictions and how long does it take and to be a practitioner, I would say?
Yeah, there really are a special interest groups within ACBS for many, many different disciplines, ranging from social work to occupational therapists to psychologists, mental health therapists, depending on the designation in a given organization. And there does need to be some training. There's much more available than there was even a few years ago. Some sort of structured supervisory context, a training protocol. There's a new book out of ACT for psychiatrists. It just came out. It was published. Oh, we got someone holding it up. And it's interesting. It was published by the American Psychiatric Association, written by an international panel of physicians. So we'll have to see what kind of play that gets. But I was pretty thrilled to see that that book is out.
Mhm.
Um, and then there's a matter of, designing a training program to fit a particular context. And it sounds like you have a resource with your medical community, who even has the latest books.
So one aspect is to empowering our trainees and our workforce to use ACT, even if they are not the delivery agents, right? To give them our trainees in medical school, in nursing, how to use this matrix in order to engage in conversations and to accelerate health. But also for at the organizational level, I can see how many of our leadership members could, benefit from using this framework.
Yeah, the executive director of the agency, I serve as medical director, uses the matrix in routine meetings, board meetings, executive meetings. She just has the matrix sketched out in front of her, and she takes notes during the meeting and just puts in comments quadrant by quadrant.
Interesting.
And so is able to use that to structure the conversation, to notice when people are getting caught up in left-sided reactivity, and then to say, okay, well, given that that's what you're reacting to, underneath it, you must be concerned about this. What's a little more valued, a direction we could move with your concern?
Yeah.
And so this doesn't have to be limited, because that's exactly what I've done in training in corporate settings, where people learn how to apply that skill set and then are able to manage routine interactions differently. And then when you add in Ostrom, I think it really empowers an organization to be able to proceed more effectively.
And one of the goals that we have also is using our leveraging on the promotoras in the community. And we want to steer conversations about cognitive changes with age. We want people to be aware of changes and to actually not be ashamed to look for help. And we want promoters to steer that conversation, but when we confront them about, in the trainings that we do, I notice there is so much resistance because they have this baggage that prevents doesn't help them to actually steer the conversation.
Well, I think that's where approaching this as acceptance and commitment training, not therapy, and skill building, right, not treatment. And if it's part of, this is the way our program operates, or this is the training we're offering, it shifts, I think, the context. And once the matrix is in play, one of the cool things about it is no matter what comes up, you can always say to someone, well, that's interesting. What quadrant do you think you're in with that one? And you're engaging that perspective taking skill in the moment. But it's like, don't just take my word for it. Go home tonight and just kind of, keep a mate. You can, here, if you just do this on your hand, you can take a matrix home with you tonight. And then you can play with it a little bit. And I think then it facilitates being, as I say, more descriptive than judgmental. But yeah, if it can become part and parcel of the way people operate, then we're in business. I must say, I know we're moving up towards running out of time, but when I first heard about that little exercise, of cover your eyes, I thought it was pretty cute. So I made a horrible mistake, it turns out, because I showed that to my wife. And the next time I was going off about something pretty unreasonable, she just looked at me and she went, and talk about being hoisted by one's own petard. I mean, you know, she nailed me dead in my tracks. It was like, oh, okay, yeah, I got it. I got it, sweetie. So, right, I mean, once you get it, you know, then you can run with it.
Yeah, thank you so much. I really enjoy it. And I see a lot of potential. So let's continue our conversation. And we've been looking for.
You know, I'll just await further word as to how we might move with this. You know, I think it's really cool that you have some local experts to serve as resources. But if I can add to the conversation, then Gladys, just let me know, because you know, I think it'd be pretty cool to see how this could be of help.
Yeah, thank you very much. We also have here Dr. Minor from the business school, and I can see also how this can help us to interact. Michael, do you have any?
Actually, I have a question about the word pro-social. Pro generally means for or in favor of, and I just, where did that, well, what does it mean? What does that title mean?
I think when David Sloan Wilson and Steve Hayes were collaborating, you know, they were looking to foster more kind of social interactions, helping people behave pro-socially. And so I think it originated from that kind of conversation. But hearing about business, please know David Sloan Wilson has a strong connection with the Stern School of Business at NYU. And they have a couple of major projects going on with ProSocial. If you go to the ProSocial website, you'll see they have a major project going on with Shopify,
Yes.
which, if you know, Shopify is like the largest online facilitator of commerce beyond Amazon. And they have a major project going on with the CEO there. And so there are outreaches into the business sector with ProSocial that might prove of interest. And if you have a chance to check that out, please let me know, because you know, that's an area of personal interest to me. I do a lot of work in business sectors too.
Thank you. Appreciate
Oh,
it.
indeed. Yeah. Thanks for your interest. Thanks for coming.
Great. Well, it's, you know, we're past 5 p.m., 6 p.m. So thank you so much. Yes,
Oh.
it's time. Thank you very much, Dr. Libman, Dr. Sokolowski. It's a pleasure to have you.